Hi, everyone. My name is Evan Veration. I'm the coordinator of the Clarence Central School District Family Support Center. And in addition to connecting folks with direct mental health support and counseling services, the Clarence Family Support Center is also committed to providing opportunities for our community to become better informed on issues that might be impacting their family, their friends, or the individuals they might work with and encounter in their day-to-day lives. Perhaps most importantly is that this information, to the greatest degree possible, is coming from sources who are well established and experienced as experts in their respective fields. Today's presentation will be focused on understanding and supporting those with serious mental illnesses, notably schizophrenia. And while schizophrenia and psychosis may be lower incidence areas within the spectrum of mental health, they can often be some of the most difficult to navigate for the individuals they impact, as well as for those within an individual's network of support. With us today is someone who has spent her entire career devoted to improving the outcomes of individuals living with serious mental illness. She has extensive experience in both the clinical setting, providing direct treatment, as well as leading innovative research and supporting those living with severe mental illness. Dr. Aaliyah Warner is an associate professor and licensed clinical psychologist in the Department of Psychiatry and Behavioral Sciences at the University of Texas, Houston, McGovern Medical School. In addition to the aforementioned roles, she also serves as the managing director of the UTHealth Psychosis Specialty Clinic and provides evidence-based psychosocial interventions for individuals with schizophrenia spectrum and related disorders. Dr. Warner is highly involved in education and supervision of psychology and psychiatry trainees. She is also involved in various national and international organizations that aim to promote high-quality, serious mental illness training programs, professional practices within the specialty of serious mental illness, and dissemination of serious mental illness research. She is a founding member and current board member of the American Board of Serious Mental Illness Psychology. And fun fact, also a former high school classmate of mine. So Aaliyah, thank you so much for being willing to provide some insight on this topic and some education for our community here in Clarence and Western New York. And just really happy to have you kind of be a part of our team, even just for a day.
Thank you for having me. I'm really excited about this area, and I think it's really important that as many people get as much education as possible. And I'm obviously very enthusiastic about this population, so I'm very happy to share.
Excellent. So I will leave you to it. For those of you that are watching, this will be posted in a variety of locations on our website, on the school district YouTube channel, and there will be timestamps. So if you're watching this and just starting it and decide you don't want to watch the whole thing right away, it will be timestamped so you can kind of go through and click to the sections that might be the most relevant to the information you're looking for. So with all that being said, Aaliyah, I will leave it to you.
Thank you. Okay, so I'm excited to talk about some effective and practical early interventions that we can use for schizophrenia. I'll give a really brief overview of what schizophrenia is and some of the commonly held misconceptions. I'll also talk about different risk factors, the etiology of schizophrenia, basically, and some warning signs to look out for those that have not developed schizophrenia yet. I'll talk about early interventions, different supports, and perhaps most importantly, some practical tips that anybody can use to support individuals with schizophrenia. And I'll end by giving an overview of different levels of care, including hospitalization. Okay. So real briefly, we kind of synonymously use psychosis with schizophrenia. Schizophrenia is basically the main mental illness or a diagnosis that's associated with psychosis, and psychosis is more so a collection of symptoms, not necessarily a disorder. But still, we sometimes use them interchangeably. Like Evan said, there is a low prevalence, but it does have some of the highest impact on individuals' lives and also on our mental health system. Typically, the age of onset is between 16 years old and 35 years old. So it's particularly important for people who work in the schools or people with adolescents and young adults to be aware of the different types of things that we can offer our folks with schizophrenia. We don't know exactly why it happens yet, but our best guess is the neural diathesis stress model. Basically, that means that there is some genetic risk if we have like a family history, for example, or other things that happen during development, which is paired with a stressful environment or other types of stressors that combine to engender basically a serious mental illness. And psychosis in general is associated with all of these disorders, among more. So sometimes people that use substances or have a serious medical illness can present just like someone with schizophrenia, but the treatment is obviously different. So we consider schizophrenia to be the most debilitating psychiatric disorder because of the widespread impacts. People with schizophrenia can live up to 25 years shorter than the normal life expectancy for a variety of different reasons. One of them is suicide. They have among the highest suicide rate among mental illnesses. Also different types of morbidity. The majority of people with schizophrenia will also have another diagnosis of a physical or medical illness in addition to another type of psychiatric disorder. It really impacts people's social lives. Few are married. Most tend to have very few close relationships. They tend to attain lower levels of education, more unlikely to have full-time employment. And oftentimes people are kind of taken, their independence is taken away because they have difficulty completing everyday activities. So the main symptoms are as follows, but everybody with schizophrenia is different. So people don't tend to have all of these symptoms, and someone who has some of these symptoms and someone who has totally other symptoms can look completely different, but they both meet the criteria for schizophrenia, which is similar to other mental illnesses. The most common are hallucinations and delusions. And hallucinations are basically experiencing anything in a sensory modality without an external stimulus. So things like hearing voices, seeing things that aren't there, smelling things that aren't there, feeling things that there's no reason to be feeling. Delusions are pretty much strongly held beliefs that are illogical or there's no evidence to really back it up. They're inflexible, so they're really hard to change. And they usually guide behavior. People with schizophrenia can also experience disorganized thought process or speech, which basically means that their thoughts are kind of jumbled. And when they try to communicate, it doesn't come out in a way that is necessarily understandable. They make kind of illogical leaps between different topics, and it's pretty hard for them to answer a direct question. People can also have disorganized behavior, which is basically doing things that don't make sense or are not goal-directed in any way. It's one of the reasons a lot of people get trespassing charges because they don't know what they're doing and they are wandering and trying to do something that isn't logical. Negative symptoms are a really big part of schizophrenia, and they account for a large majority of the impairment that people experience. And these are things like taking batteries out of somebody, basically. So experiencing less emotion, experiencing less motivation and ability to get started and get things done, difficulty thinking, sometimes a little bit slower, like walking or slower talking, slower pace of thinking. Okay, so some facts versus myths. A lot of people would say that individuals with schizophrenia are violent. There is less truth to that than there is truth to that. People with schizophrenia are much more likely to be victimized than to perpetrate. And compared to other mental illnesses, they're actually as likely or less likely to offend people, which is kind of interesting. They are a little bit more likely than the general population to perpetrate violence, but some of the larger studies that have been done kind of take out what that can be accounted for. So really, the violence that people with schizophrenia commit is oftentimes explained by substance abuse, medication non-adherence, and also repeated exposure to violence when they're young children. But substance use is one of the big ones. Most people think that people don't recover from schizophrenia. That is not true. Although recovery is nonlinear, just like substance use sometimes, like people will get better, sometimes they'll relapse, they'll get better, they relapse. But we generally see that most people experience recovery at least at some time. There are some big studies that follow up with individuals with schizophrenia over 10 years. And so some of them found, so after 10 years, 49% of the individuals were in clinical remission, which means they did not experience any symptoms. 37% reached functional recovery, which meant even if they were experiencing some symptoms, they were manageable, so they weren't being hospitalized, they were working, they had social relationships, they were involved in the community, or they were in education. And 25% had a complete recovery, which is both of these together, and sometimes also means that they no longer take medication. While medication is important, it's not the only treatment for schizophrenia. We have a lot of different things that work. So even if people don't want to take medication, it's still okay. Getting them into treatment is really helpful because we have a variety of things that can be helpful. I'm not going to go too much into this, but just to give you an overview of what the course of illness kind of looks like. So when I say premorbid, that just means there's no signs of symptoms. We're talking about like childhood, right, or early adolescence. At this stage, though, we're pretty prone to different risk factors, and we'll go over in a moment. Before people experience the first onset of schizophrenia, we usually see a pre-psychosis or a prodromal period where we start to see some signs that things are a little different. We see some social and cognitive impairment, some non-specific symptoms, and we see that people are really seeking help, but they don't know really what to seek help for. I'll go over that in a moment. About 15 to 40% of these folks that are in this group of folks will develop schizophrenia. And after the first onset of symptoms, we see the most changes. This is oftentimes also the most psychosis someone will experience. And most importantly, they have the highest risk of suicide. I believe it's an 87-fold increased risk of suicide. And 13% die by suicide in that stage. And then after onset, like I said, we have like a nonlinear recovery. We do expect some relapses, but there's a lot of ways to prevent it or minimize. And generally, we see a good outlook if they're receiving the treatment that they need. So in terms of early interventions, these are the two areas that we're going to be focusing on. Before we get to that, here are some main risk factors and some risk factor groups to look out for, because as I'll show you, early interventions also focus on these high-risk groups. In terms of risk factors, so I talked about how genes and environmental stressors or psychological stressors kind of overlap to create a serious mental illness like schizophrenia. We have so many different risk factors that we've identified. It's kind of all over the place. But these are some of the more common ones that we find or that are replicated in other studies. So family history is one, although it doesn't have as much of a heritability index than one would expect, but it does put us at higher risk. Basically, any complications that can occur when someone is in the womb, or birth complications, or anything right after birth. Childhood trauma or just adverse events, stressful things like migrating, the environment in which we grow up and the resources we have, or SCS, advantage or disadvantage, and also illicit substance use. For some reason, cannabis is one of the biggest issues here. So when people are using marijuana in adolescence, we do see an increased risk for schizophrenia. And I believe there is some information that recently came out about Canada, because it has been legal there for a while, and they saw a drastic increase in the onset of schizophrenia, which is really concerning. Not necessarily causal though, but definitely correlated. Okay, so how do we figure out who is in the pre-psychosis phase or who is at risk for developing schizophrenia so we can capture them as quickly as possible? We have these groups called ultra high risk groups. Sometimes we call them clinical high risk groups. And they're individuals that meet these different criteria. The most important one is the first one, which is attenuated psychotic symptoms. Attenuated just means subthreshold psychotic symptoms. But basically, this group of folks that start to experience some types of psychosis are at 200 to 400% times more likely to develop schizophrenia within the next year. And of the three groups, they account for about 93% of those that actually transition. I don't really need to go into the other two, but there are some other groups that are important to capture. Okay, so we have the ultra high risk groups, and we also have another model where we look at specific symptoms that are highly likely to indicate that there may be an impending onset of schizophrenia. But again, these are heterogeneous in duration and symptom presentation. But generally, we start to see these things occur about 5 years prior to onset. So the prodromal period can be quite long, but it can also be quite short. These symptoms tend to be pretty nonspecific. And even though there's a substantial increase in help seeking among these folks, oftentimes providers don't know what to really do with it. And so they're not accurately captured and get into the treatment that they need. The symptoms can be kind of vague. It can look like depression. It can look like stress sensitivity, sleep disturbance, which is a really big one, actually. There's a lot of literature that indicates that insomnia can predict or precipitate this transition into schizophrenia. It also continues to reinforce schizophrenia symptoms if sleep is not improved. We see negative symptoms. So those symptoms I was talking about where people are withdrawn, they're not doing a lot of goal-directed behavior, they're not really socializing. And then we have our attenuated symptoms. So these are perceptual abnormalities, like more so illusions, or hearing muffled voices or whispers, or maybe like differences in tactile experience. Or seeing something that's just slightly off, like shapes, or seeing faces in the wall that aren't necessarily crisp, but have some difference there. Also, we see a little bit more unusual thought content. This is particularly related to suspiciousness or paranoia, or even the way that they're talking is not necessarily very linear. You kind of have to follow them quite closely to really understand what it is that they're trying to get at. Those are just some examples. Oh, most importantly, though, usually the first sign is unexplained academic decline. Because first, we tend to see some of the cognitive changes and functional impairment and social impairments. So oftentimes in the schools where we can first see actually that these symptoms are setting in, and it might be concern for further intervention or evaluation. So what are early interventions? There are two types of early interventions generally. One is capturing those folks that are at high risk for developing schizophrenia before they have it. And the goal here is to identify them early, get them specific treatment that they need to reduce the likelihood that they will develop schizophrenia. And then the other type of early intervention is once people start experiencing symptoms, getting them into specific treatment as quickly as possible with all of the evidence-based interventions that I'm going to talk about in a moment. One of the driving hypotheses for early interventions is this idea of the duration of untreated illness or psychosis. So one of the goals here is to really rapidly get them into treatment, because there's a large hypothesis that the longer you wait to get into treatment, the worse your outcomes or disability is generally. I'm not going to go through these, but there are lots of high quality studies that put out different recommendations for different stages of illness. And here we're talking about the pre-psychosis or prodromal area that indicates that early interventions are helpful. They can substantially reduce the conversion rate. Many of the studies have reductions that are more than 50% in terms of the transition rate. And we have effective treatments for this, even though psychosis hasn't necessarily set in yet. And that mostly includes cognitive behavioral therapy. And some recommend medication, but the risks and benefits are a little iffy for younger folks. Okay. So in terms of treatment for schizophrenia, this is perhaps the most well-cited list of recommendations, but there are recommendations for both psychosocial treatment and also pharmacological treatment. And as you can see in the middle, a lot of this is phase specific, meaning what are they presenting with? Where are they in the course of illness? But for the psychosocial pieces, this applies to all people with schizophrenia. And the point here is that there's several things that are effective and very effective. Most of those psychosocial treatments that are recommended are translated into this early intervention type. So coordinated specialty care is a treatment model that is used for individuals on the first episode of psychosis. These are kind of our gold standard. We have the most support for this type of treatment for this phase of illness. So they're comprehensive teams that come together to provide different services for the patient, depending on what the patient is interested in pursuing. And they also provide services for the families. Again, the goal here is to give them as much treatment as needed to prevent further disability and to improve long-term outcomes. Recovery-oriented care is extremely important for any serious mental illness. And that means we're instilling hope. We give people the autonomy that they deserve because they are people. And we really structure treatment around what are their goals and aspirations, and how can we identify barriers for them reaching those and intervene so that they can continue to reach those goals that they want. This type of treatment is usually limited 2 to 3 years, unfortunately, because people really do need these services long-term. So generally, coordinated specialty care includes medication, if they want it, psychotherapy, such as cognitive behavioral therapy, or IRT, which is individualized resiliency training, which is specific to CSC models. Family psychoeducation, supportive employment and education. So that's working with people that are employment or education specialists to get them back into school or to get them competitive employment and teach them different job-related skills and interviewing skills that are important. And then, of course, case management. So just managing their care overall and also getting them connected with resources that are needed. So far, we have some pretty good outcomes regarding CSCs. We see that they're hospitalized fewer times, and when they are rehospitalized, they spend fewer days in the hospital. They're arrested less. They tend to come out with fewer symptoms or sustained remission and improved GAF scores. So a GAF score basically just means that their overall functioning is higher across areas of living. CSCs also tend to result in much higher percentage of people engaged in employment and also education, depending on the age range and what it is that they want. Improves quality of life, improves insight, meaning awareness that they have an illness, awareness that they need treatment, and people like it. So there's a really high level of treatment engagement, which you don't typically see in even just regular outpatient services. Okay, so what can we do? Here are some different strategies that I will go into. But first and foremost, if you can get somebody connected with appropriate treatment, that's probably one of the best things that we could do. And all of these others are different things that anybody could do. So I'll go over like practical strategies, but I first want to start here by emphasizing how to keep yourself and them safe and keeping the environment safe. Because oftentimes escalation can occur, and these are ways that we prevent escalation or de-escalate. Non-verbal behavior. Delivery or the way that you say something is way more important than what you say. I believe the statistic is like 90% of outcomes of communication are based on how you say them, not what you say. And so we want to deliver things in a calm manner We want to maintain open and relaxed postures. Try to refrain from invading somebody's space, and limit the use of tons of hand gestures, right? Because things can be easily interpreted to be threatening, even if they aren't. Effective self-talk. I think everybody experiences some negative self-talk when we're in situations that we don't handle day to day. But it's really important to remind yourself, I can handle this, I've done this before, or I know what to do, because that does increase your effectiveness overall. One of the most important things is to show empathy and to listen. And we'll go into that a little bit more in specifics. Things to avoid: limit setting or activity demands. This is stopping someone from doing something that is unreasonable, like telling somebody to calm down. We know that doesn't work for anybody. Or stop saying that, you can't do that. Activity demands are basically telling someone to do something that they don't really need to do, like telling someone, go over there, or sit down, or lower your voice. These can often create some type of negative reaction. Unnecessary no's. Saying no to reasonable requests. These are things that often result in, like, because I said so, but there's really not any reason. Try to avoid stigmatizing language. Don't call people schizophrenic, right? Someone with schizophrenia. Schizophrenia already is probably one of the most stigmatized mental illnesses, and calling someone by their diagnosis can create a lot of self-stigma, which is really not helpful for outcomes. If people are experiencing symptoms, it is unhelpful for you to tell them that they're not real. Oftentimes, this comes from a place of someone trying to help by saying, don't worry about it, it's not real, right? Those people aren't really here, or that belief is not accurate. But what happens is it really invalidates the person that's experiencing it, because they experience these symptoms as if they are absolutely real. So like in MRI studies, for example, when people are hearing voices in the scanner, it activates our auditory cortex the same way that if I was actually hearing something, that would light up. So their experience is quite real. It's different though if you're in a like a therapeutic relationship with them and you have rapport, and they've learned to tell themselves that it's not real as a form of coping. But I would avoid the statement generally. Don't call people crazy. It goes with stigmatizing language. What is crazy anyways? And how is that helpful? Don't blame people for mental illness. It is not their fault. They do not want to be experiencing what they are experiencing. And oftentimes people will punish people for like expression of symptoms, like doing something that doesn't make sense, or yelling at their voices, for example. Punishment is not really appropriate here. What we really need is someone to help them reduce distress. That's just going to make things worse. Okay, empathy and validation. Empathy goes a really long way. It can help moderate their distress, and it can improve our connections. And this is for any relationship, right? Or even any new relationship or acquaintance, but particularly so for psychosis. People with psychosis tend to feel very unheard, misunderstood, and set aside. So this can really go a long way. Some might have difficulty imagining, how do I empathize with these individuals' experiences, which is understandable. And these are a couple tips that I have. So one, oftentimes when people are showing anger or frustration, they are actually really scared and fearful. So what they really need is comfort and recognition that they're angry, and some empathy that maybe it makes sense that you're angry, right? Not everybody grows up with parents or family or caregivers that have great coping skills. A lot of people grow up with other people that have mental illness or power boundaries, or people that just don't model effective ways to cope. And so oftentimes when you're meeting somebody who is not well and they have maladaptive behavior, usually they're doing the best that they can with what they have. They haven't learned those coping skills that they need, and they need to learn them. Also, for people to change, people need to feel supported. They need trust, and they need to feel safety. Assuming environmental causes versus internal characteristics. This is called the fundamental attribution error, which everybody does to some extent. When somebody does something that we don't like or is bad, we tend to automatically assume that that is representative, that person is who they are. That thing is bad, that person is bad. Things are not that simple. It can be more helpful to remember that the way that they were raised, what they were exposed to, is probably way more explanatory regarding how they behave and what they did than who they are, right? So the question might be, what happened to them to make them the way that they are now? And also, this isn't about me. More often than not, when someone's experiencing psychosis and they're upset or they're behaving in a way that you don't like, it's not about you, it's about what they're experiencing. This happens a lot too in families when people experience like mania or extreme paranoia, and they're like threatening or accusing you of doing something, but it doesn't mean that like deep down that they don't like you or that they find you scary. It's just an expression of what they're experiencing internally, unfortunately. So all of those can be helpful in cultivating empathy. After we cultivate it, we need to express it. So how do we express empathy? Listen, show that you're listening. One way to show that you're listening is to ask open-ended questions. And those are any questions that don't result in a one-word answer. So asking them more information about whatever it is that they're talking about automatically makes people feel heard. Reflections are excellent. Reflections are basically small summaries of what they've told you, and you kind of parrot it back. Sometimes you can add a little oomph with reflections. So if somebody's telling you something and you reflect back basically what they said, but add an emotion, it can be even more impactful. Validation. Validation is basically finding the kernel of truth and communicating that to the other person to essentially communicate that they are valid as a person. But we only validate what is true and needs to be validated. But basically, by intentionally focusing on what is valid that they're doing with empathy, it facilitates like their emotion regulation, but also ours, because we're bringing ourselves to that place where we can understand, right? Typically, internal experiences are valid and understandable. That means typically people's emotions are valid, right? We often will only validate an emotion and not a behavior, depending on what's valid. So if somebody gets really angry at you because they think that you ate the last piece of cake, and then they talked crap about you to their manager, you can validate that. Yeah, okay, you're angry. I can see that. I'd be angry too, right? That's valid. But you don't validate that you ate the cake because you didn't eat the cake. And you don't validate the inappropriate behavior of them talking bad to you about your manager. Those things are not valid. So it's also kind of a form of reinforcement in a way. So what about psychosis? Same thing. Often we want to validate the emotion. Sometimes they don't necessarily share the emotion that they're experiencing, but it's usually pretty obvious what kind of emotion they're experiencing. So you can validate the emotion, but not the delusion or psychosis or any other inappropriate behavior. And we'll go into that a little bit more depth. Another strategy is using and, not but. So when we have two clauses and we use but, we invalidate the first part. We want to use and. So for example, I see that you're angry, and I need you to sign this for me now. It doesn't invalidate the first part, but if you say, I understand you're angry, but I need you to sign this for me right now, it's now invalidated the first part. And sometimes we need both things to be true, and they feel different. They make a different impact. Okay. So some specific symptoms. what do we do with hallucinations? So in therapy, we focus both on behavior and cognition, but anybody can use these behavioral techniques with individuals that are hearing voices or seeing things or feeling things that aren't there. Typically, the more out of control someone feels regarding their voices or hallucinations, the worse they are, and also the worse that they react to them. So if we can increase a sense of control, typically it reduces distress and sometimes reduces the frequency and intensity of the voices. The voices are highly correlated with stress. The more stress someone has, the more voices they're going to have, and vice versa. There are also certain times of the day that people tend to hear more voices. Oftentimes when people are alone with like no auditory stimulus, no sound, or at night, people do tend to hear them more, which is something to keep in mind. So what can we do? We can give them different strategies to decrease the intensity or the distress related to the voice. Anything relaxing, doing some breathing exercises, taking a bath, reading, whatever it is that's relaxing can be helpful. Listening to music or using earplugs. Typically one or the other works. And they're using earplugs is quite a fascinating phenomenon because it's an internally generated experience, but sometimes putting something blocking the external does help. And one of the main theories there is that if you're hearing from both, then they kind of compete and get louder. With earplugs, then we're just kind of diminishing that thing that they need to compete with. Talking to other people. This is a really effective one. A lot of times in therapy, if people say that they hear chronic voices all the time, if I ask them right then, they're not hearing the voices. If they go talk to a family member or they're engaged in conversation, they're not hearing voices. You can really only pay attention to one or the other most times. If the distraction requires enough attention. If people are just watching TV, so easy to tune out, and so voices usually tend to intrude. Doing something meaningful, ignoring the voices or humming, and keeping busy. The more engaged that people are with anything, the fewer voices they're going to hear. So this is kind of how this cycle works in terms of control. If we are hearing a voice and we try refocusing on something and it helps, it increases our sense of control. And then it tends to impact, the voices themselves and how distressing they are. At the same time, I want to mention that people can hear voices and still live meaningful lives. Most people will experience some residual symptoms even in treatment, and that's okay. Then we have to kind of work on the relationship and what they think about the voice. But both can be true. Delusions. Okay. Here's a little acronym to help you remember what you can do. STEP is the acronym. So let's say that somebody was eating food and it tasted strange, which is a common hallucination, actually, like a taste hallucination. So they're eating something, it tastes off, and they've been worried that the FBI is persecuting them. They're going to take them away and torture them for the rest of their life. But they want to poison them in their food so that they can take them when they are unconscious, so they can't fight back. That is very elaborate. But so the first step is to summarize what they told you. You ate something that tasted off, and you're now concerned that someone's going to try and take you and torture you. Is that right? Test to make sure you're accurate. They'll correct you if you're wrong. Then you empathize with the experience. So just like validation, here what is valid is their emotion. Wow, that sounds really scary. I can see that's really distressing, which is true. If you imagine someone was trying to poison you and you're going to be taken away forever to be tortured, it sounds terrifying. So whatever it is that elicits in you is probably true for them. So yeah, that sounds really distressing. And then proceed with intervention. That sounds really distressing. I wonder if there's something that we can do that'll make you feel a little better. Without this full strategy, particularly the empathy part, People are not so interested in trying to think about their experience differently or trying something that might help because it feels so true and so imminent that it feels dangerous to kind of shift focus and not be like overly alert about it. But when we point out, oh, wow, this is really affecting you. I wonder if we can make you feel better. It's an easier transition to try to do something else. Okay. So some of these are some of the approaches that we use in cognitive behavior therapy for psychosis, which is the most effective therapy that we have. But I kind of pared them down to different interventions that most anybody can do. You might need to practice or figure out what you're comfortable with, but these are doable. You don't need a PhD in psychology to do them. They break down into two different areas: change or improve their thinking and change their behavior to manage distress. The top one is a little bit, it takes some practice, but it is really effective. Can we find alternative hypotheses? We're not saying your delusion is wrong, what's right instead. We're backing it up to the initial reason that they had that belief in the first place. So for the example I just used, the precipitant is they tasted something that was strange, right? So we're trying to find, why are other reasons that you tasted something strange? Is there something more probable than the FBI coming after you, right? So backing up to that piece, why might something taste strange? Well, were you eating spoiled food? Did you just brush your teeth? Did you burn your tongue, right? Is it bad food? Is there a lack of seasoning? There's so many reasons why something might taste strange. And by modeling this and practicing them finding alternative hypotheses, the easier it'll be for them to do that on their own and just like slowly kind of deconstruct some of those delusional systems. It's also helpful for non-delusions too, because one of the big cores of delusional beliefs is poor self-esteem or just like negative self-views. And so that is another thing to keep in mind. Getting someone to agree that their delusion is wrong is not going to last a really long time. What actually lasts is fixing the problem that the delusions are being manifested for, because they do serve some type of purpose theoretically. Problem solving. So after the first onset of psychosis, people tend to lose a lot of their cognitive abilities that take a lot of cognitive effort. They have a lot of other stuff going on. So sometimes they need to relearn how to problem solve and how to think in a way that is informed. So we take this down to like the most simple steps. What is the problem? Let's specify it. What are all the potential solutions? What are the pros and cons of each solution? Which one is most reasonable? We've identified this. Now, what is the first step in problem solving? We need to make things as easy and as attainable as possible. Okay. Managing distress and changing behavior. Coping skills. People need coping skills. Any type of coping skill. You'd be amazed how many people come into my office and they've not learned a single coping skill before. At the same time, a lot of people have coping skills and they just don't know it's called a coping skill. So we can elicit things that have worked in the past and also add different exercises that might be helpful. Getting them active, getting them social, those are all really helpful. If you feel comfortable, targeting sleep can be really helpful, particularly insomnia, or any other types of sleep disorders like sleep apnea. They probably need a CPAP, anything to improve sleep. This one's a little bit more complicated too, but reestablishing safety cues. When people are paranoid, they go out in the world and all they see are indications that they are unsafe, which makes sense. Wouldn't you do that too if you felt threatened? We can help them shift focus on what is safe in the environment and get them more used to focusing on what can I see that makes me feel safe enough that I can go out into the world and do things. Okay, a little bit more on this. On the left, look, point, name, and grounding. I teach every single one of my patients these. They're super easy, and I've never heard anybody not find it effective. And you can do this at any time. So look, point, name is really just the first part of grounding. So I usually start by tell me everything that you see, all the objects in the room. Then tell me all the colors you see in the room. Take a couple of deep breaths. Tell me all the things you can smell. If they can't smell anything, have them smell their shirt or something else so that kind of activates their senses. Tell me everything you hear. I usually give them quite a while with this, not quite a while, but some time, so that they can start picking up some of the subtle sounds also, like the air conditioning or the computer monitor, right? Can you taste anything? And tell me everything you can feel. Usually people aren't used to this one, so I usually have to guide them a little bit. Can you feel the temperature on your hands? Is it colder or warmer than your hands? Can you feel where your shirt touches your body if you focus on it? If you wiggle your toes, can you feel where your toes hit your socks or your shoes or your feet on the floor or where your back touches the chair? This skill can help with any type of distress, even like the most acute types of stress. This, I think, was originally was used for PTSD when people are experiencing like very active stress response. Okay. Other things you can do. So I already talked about alternative hypotheses. Using praise. When they do something good, praise, reward, right? They usually feel really poorly about themselves. So praise is awesome. Use affirmations. If you have good things to say or you find strengths in them, tell them that. Or you can help them come up with their own affirmations. Write them down so that they can reference them in the future when they're not feeling so good. Do something enjoyable or do something that demonstrates mastery. That just means if they're good at something, have them do that. If they're really good at wood shop, have them work on a project, right? Or if they're really good at making coffee, put them in charge of making coffee for the group, right? ABC categories is a fun distraction. Usually I go back and forth with someone on this where we start with A, and we go through the whole alphabet using any category. So TV shows and movies is something that I like, but if people are not like thinking so clearly and quickly, I'll start with animals or food. So we go back and forth. So A, alligator. You do B. B, bear. C, catfish. I go through the alphabet. And it gives them time to kind of distract themselves from whatever is giving them a lot of stress, so that they kind of regulate and kind of come back to where they were before that. Go outside and walk. It's crazy how helpful a walk can be. Any relaxation skills. Instill hope. There is a lot of hope for anybody with serious mental illness, and they do need to know that because usually they feel hopeless and helpless. Destigmatize. There are so many famous people with schizophrenia or with other SMIs. It's helpful for them to know that. It's also helpful for them to learn accurate information about schizophrenia. And there's plenty of ways to destigmatize. And keep track of what works. Our memories are so biased. If someone isn't feeling well, we're not going to remember what worked because nothing works, right? So when they do find skills that are helpful, have them write them down so they can reference them later. Sometimes I'll make a coping card, which is just an index card. And on one side it says coping skills, on the other, all the coping skills that they found helpful before. Then it's easily accessible right when they need it. Okay. Regarding treatment, there are several levels of care. The lowest level care is outpatient treatment. You see your doctor, your therapist once in a while. ACT teams, assertive community treatment or assertive outpatient treatment, which is more involved in the legal system, is a multidisciplinary team that comes to your home to provide services multiple times a week. It's a very effective form of treatment. It's particularly for those that are hospitalized repeatedly because it reduces hospitalization. Intensive outpatient and partial hospitalization programs are programs where you basically go to the facility most days of the week and spend a few hours there in treatment. And then we have hospitalization. There's different levels of that too. People can voluntarily go to the hospital, people can involuntarily go to the hospital, but even if someone's there involuntarily, it does not mean that they will receive involuntary medication. Court-ordered medication is a very, very high bar. You have to go through the legal system when people do that. It's really hard for physicians to actually get court-ordered medication allowed. Something to keep in mind. And usually they only grant it if someone's being violent. Okay, so hospitals are different across regions, states, and the country. But typically, a psychiatric hospital that's not a state hospital, the aim is stabilization of the most eminent symptoms. And typically, people are only admitted to the hospital if they present with imminent risk for harming themselves or others. And that means like serious injury or death. Hospitalization has its place. It improves safety in the short term. There's usually no objects in there that anyone can harm anyone with or even themselves. Sometimes when you're trying to get into care, it can take so long to get a new appointment, right? One of the benefits of hospitalization, if they meet that criteria, is they get almost immediate assessment and treatment. And usually they discharge you with follow-up resources or follow-up appointments. The cons, people don't like to be hospitalized typically. It can be very traumatic. There are a lot of things that can happen that can be traumatic, basically. And although they can do a good job of stabilizing someone, they don't optimize. Sometimes they're over-medicated because they needed to get those symptoms down as quickly as possible, and there's really few psychological or psychosocial treatments there. So it's kind of a Band-Aid. When it is necessary, often it is, there are a couple things you can do. You can take them to an ER or an ED or a hospitalization, or sorry, a hospital for evaluation. If you have a choice to go to a medical hospital versus a psychiatric hospital or psychiatric ER, do the psychiatric one. Oftentimes, if you take someone to the medical hospital, they don't know how to evaluate accurately for psychiatric admission, and people wait there for days waiting for a bed to open up in the psychiatric hospital, oftentimes without any psychiatric treatment. So it can be unhelpful. If you want to initiate an involuntary hospital admission, you can file a mental health warrant with the court. Sometimes it's called something else in different areas. It's not always called a mental health warrant, but it's basically the same thing, or an emergency detention order. There's different names. You can also just contact emergency services. You can call 911. If you do, specify that it's a mental health emergency, and if available, ask for a crisis intervention team responders, because these people are actually trained to work with people in mental health crises, and it's often just less dramatic, and there's less likelihood of harm from the team to the patient, right? Almost always, if you do call emergency services or the police are the ones that pick them up, they are handcuffed. So that's something to keep in mind. So what a hospitalization usually looks like, so they're usually on a unit with several other individuals with serious mental illness. You typically have roommates. There are lots of restrictions on what you can bring. Usually can't bring like your own soap or lotion or whatever, because there's a chance that there's like alcohol or contraband in there. Oftentimes you also can't take shoelaces or like hoodie strings, because they want to make sure that there's like absolutely no chance that someone is going to harm themselves with anything. If the patient is an adult, expect that you won't hear anything from the hospital unless the patient has signed consent specifically for y'all to talk. HIPAA compliance is a very serious thing in the hospital. They can't even tell you if they're there usually, unless you have guardianship. And like I said, there's very little psychosocial support. So I wouldn't expect to go to a psychiatric hospital and have like a full course of therapy or skills training or support. At least the hospital here, the acute hospital, the average length of stay is about 7 days. And that can be pretty typical because it's a high volume. We have a high need for more beds. And basically, as soon as someone's stable, we kind of send them out. If they're psychotic, though, they do tend to be there a little bit longer than 7 days. Okay, overall takeaways. One of the best things you can do is reduce stress, increase relaxation, express empathy and validation. Those two things go a very, very long way. Model information gathering and conclusions. People need to relearn kind of how to think in an informed way. Promote hope and autonomy. An attempt to get them into treatment. Don't invalidate them. Don't invalidate their experiences by saying things are not real. Try not to blame them, belittle them, or stigmatize them further. Don't make choices for them. they're still people and they can still make sound decisions. The more independence they have that they can safely utilize, the better off they're going to be. Don't view them as hopeless or incapable. They're still capable, and threatening and being very reactive to individuals with psychosis can do more harm than good. Here are some other resources. Since we're talking about early intervention specifically, there is an early intervention program locator by SAMHSA. EpiNet is a really great hub. They do lots of research and treatment, and they have resources for basically everybody on there about early interventions. And here's a couple of training sites that you can use if you want to learn more, or you're a clinician or work in a school and you want to learn how to do like CBT for psychosis, for example.
Well, yeah, thank you so much. This was obviously highly comprehensive. Again, for anybody who ends up watching this, please understand that, there's research is kind of ever changing. So, where this stands today in February of 2025, some of the treatments, some of the resources that Aaliyah explained, obviously in another 5 years, and hopefully due to the efforts of her and a lot of the colleagues across, across the country and really internationally with these issues, who knows where things will stand in another 5 or 10 years in terms of, the research that's out there and the types of treatments that are out there. But as it stands, I just kind of want to, again, highlight the fact that, we're really fortunate here in Clarence and in Western New York to have a lot of experts, but it's also great to be able to, have connections to people that are in bigger metropolitan areas, in larger institutions in a lot of ways, like Aaliyah is, who've had a lot of experience, both again in the clinical end, but as well as in the research end. A lot of the things that were discussed, obviously a lot of this presentation was focused primarily on schizophrenia, on serious mental illness, on psychosis, but a lot of those topics and a lot of the things, especially kind of like the best practices, for anyone, whether it's a mental health provider or even just a parent, school staff, that you discussed really could translate to anyone with a mental health disorder, but really even anyone who's just struggling with their mental health for a period of time. Some of the things that were discussed. So again, if there's parents that are watching right now, or community members that might have family members dealing with maybe a more serious or acute mental health need, but maybe just we're having a rough month. Some of the topics that were discussed around sleep, around cannabis use, which again now, at least for adults with over the age of 21 in New York State, is legal. But because of that, sometimes access to those things within a household for younger people, for adolescents, is potentially possible to increase. Cannabis use, sleep, social isolation. Those are all things that no matter whether a person has a serious mental illness or just is having a really hard time for a period of time, are all things that don't really require a clinician to help support. And that as a parent or as a caregiver or community member, we can do a lot, especially as it relates to social isolation, to mitigate risk factors. So when we think about those students that we might be experiencing, or our neighbor, children who might be our neighbors within our community, who are noticing maybe some of those warning signs and noticing some of those changes in behavior, social isolation is the one thing that we have so much control over as an everyday person in their life, who might not be a trained mental health clinician, but who certainly can kind of provide a hand of outreach, and really engage with an individual. And that if that individual is experiencing a pretty serious episode of mental illness, that might not be the the end all be all in terms of treatment. But if it's someone who is just having those early stages of risk factors, just being willing to develop a positive relationship with those young people. And I say young people in particular because that's where, as Aaliyah said, the risk factor really is, in terms of early intervention or the lack of early intervention. Those are the things that really out of our office, we're trying to do a lot more of, and that hopefully within the community, for anybody that's listening, understands that they're capable of helping out with too. You as an adult in your child's life have a lot of control over their sleep patterns. You have a lot of control over, their socialization and their socialization patterns, their physical health. So there's a lot, and the other thing that Aaliyah mentioned was just that idea of autonomy and dignity. So when working with people, when working with our students, some of which can be extremely challenging. So as a parent myself of not an adolescent, but a young child who also has a lot of trouble communicating, given the fact that they're only 18 months old, giving that child, whether they're 18 months old or whether they're 18 years old, the sense of dignity and autonomy that they might need to be willing to have those conversations that might be more difficult, is really, really important. So those were just kind of a few of the notes, kind of as a more lay person, so to speak, that I took out of it, and hopefully as viewers, as parents, as community members, staff, that you might be able to walk away from too. But on a kind of aside, I had a few questions for you, Aaliyah, really that speak a little bit more to those bigger picture items that our office and myself and my role are really trying to address, as it relates to not so much addressing these crises that might occur in the short term, but how do we start building our community in a way that is more effective at being preventative when it comes to addressing mental health. So based on obviously what was discussed, but really your extensive experience in the field, is there anything that you feel like, especially being in a larger metropolitan area in Houston, that either you've seen work or that just knowing the research that you've done might work, in terms of building some innovative infrastructure within communities to support serious mental health that maybe local legislators, local community activists, and local community mental health organizations could start considering?
Yeah, definitely. So the coordinated specialty care model is mostly funded by block grants, and who knows how long they're actually going to be funded for, particularly because they don't cure something, and usually those grants are allocated for that. If there's a way to provide those types of services, not only for first episode psychosis, but also for like clinical high risk folks. So there are CSCs that kind of focus on the prodromal or predromal place, right? And they provide services for like any type of symptom they're experiencing, and also monitor progression, right? But also after first episode, we need the same types of psychiatric rehabilitation, basically. So allocating funding to some of those services in the community is very beneficial, not just for our folks, but also for economic burden. Because if we can prevent people from experiencing such great disability, or constant hospitalizations, all of these things, overutilization of services, that helps everybody, right? And particularly the mental health system, and of course the people. So a focus towards prevention is going to save many things in the long run. So prevention is really helpful. Destigmatization of mental health services in general is really important, right? Even if we're in like a pre-psychosis phase, and it's not even going to be psychosis, but it's something, we want to get people into treatment. We also have a very large population that are very low income or no income, right? And I don't know if this is how it is everywhere, but our local mental health authority provides low to no cost comprehensive services, and low to no cost medications. And on top of that, they help those individuals gain like a community type of insurance that, although it doesn't cover everything, it covers some of the essentials. So again, that's kind of in the preventative way too, right?
Yeah, because the financial barrier to getting any treatment is one of the probably more predictive factors of whether or not somebody's going to continue with treatment, getting support in the first place. I know we see it out of our office. We, through a very diverse set of grants, we're servicing anywhere between 20 and 30 young people for no-cost mental health services through those grants.
Yeah.
And again, I don't think people, again, whether it's legislators, whether it's just community members, always understand the cost.
Yes.
It's anywhere, for someone to just see a therapist, let alone some of the other more comprehensive treatments that you were talking about, just to see a therapist, you're looking at, if you were to pay out of pocket or even for an insurance company to have to pay that, you're looking at anywhere from $2,500 to probably, at least locally, what we deal with, probably $2,500 to $4,000 per year per person for someone to see someone twice a month.
Right.
And that's a lot of money for a family that might not have it. That can be a huge burden. So
yeah,
I think all those things definitely make sense.
Yeah, I think like on a more practical level too, like I said, a lot of times academic decline is the first thing that we notice, and teachers spend so much time with students that even just like broader education on these types of like presentations and warning signs, I think could go a really long way. Because one of the biggest issues we have is identification of somebody who's at risk, right? And oftentimes the teachers or other school personnel are the people that spend the most time observing and seeing these folks.
Yeah, and those are pieces of data too that like schools typically have readily available. Like we can see trends in academic decline and things like that. In terms of any current research that you're doing or involved in, is there anything interesting that people might want to delve into more if they're really into this as a topic, or if it's impacting them at kind of a personal family level? Is there anything that's happening right now, either that you're involved in or that you're aware of, that is maybe of note?
Oh, that's like a big question.
Or you can just be like, not right now.
No, I mean, there's a lot. I personally, like my research is mostly focused on rehospitalization and recidivation, like criminal behavior, and how these services prevent those things or reduce those things. But more recently, I'm really doing sleep research for schizophrenia. And it's really amazing the impact that sleep has on schizophrenia. And there are like whole new treatments that like one of the biggest components is sleep hygiene and improving sleep. And that is like a predictor of attenuating symptoms, mitigating that, and improving recovery.
Which is also interesting. So on a couple notes, from what I understand, again, not an expert in neuroscience, but what I do know is that there's been a lot of research coming out around sleep and sleep deprivation being a predicting factor of dementia and Alzheimer's. And just knowing the impact that it has on the brain, and knowing that, particularly in a school district like ours, which is overall a pretty high performing competitive school district, we have a lot of, amazingly gifted students, but who also, as a result of some of the demands that come with high levels of academic competition, have schedules that really are not conducive for a high degree of sleep. And developing those sleep patterns, either positive or kind of negative sleep patterns at crucial ages of development, I think is something that our families and even our school staff need to start considering when we hear the impact, as you described, certainly on more serious mental illness like schizophrenia, but even just anxiety, depression, those types of mental health concerns, which certainly can manifest into larger problems. The fact that sleep is such a predictive factor and such a preventative factor, I think is something that, again, we can talk about counseling, we can talk about medication, we can talk about a lot of those things, but when we think about, like you were saying, those preventative factors, just making sure our kids are getting enough sleep can really be an impactful intervention, if you want to call it that, when really it's just something we should all be doing. And so I think that's an important thing to consider, knowing that there's a lot more research, like you said, being done on that. I think hopefully will then bleed into, and it probably would take a while, but will bleed into how schools conduct their business, right?
Yeah.
Knowing that we control in a lot of cases, in the K-12 setting, we control what kids' schedules look like, what their day-to-day schedule looks like. And if we're not thinking about how that might impact their physical or mental health, we're really missing opportunities to be preventative with those things. So with all of that kind of being said, how do you see the approach and treatment of individuals with mental health needs, kind of, especially more severe mental health needs, but just in general, how do you see that kind of changing and evolving over the next decade or so? Because I think as, you know, MRI technology certainly has expanded over the past 20, 25 years, um, in addition to just some of the destigmatization of mental health in our society. How do you see things evolving over the next maybe decade or so?
Hard to know because progress in this area is very slow. If you think about how the first medication that was effective was in the 1950s, we're still using the same types of medication. We've been using CPTP and these coordinated specialty care models for, well, at least CPTP has been a few decades, right? So it's hard to know, but a lot of the research is focusing on like biomarkers, different like brain functioning, genetic predictors, and also a lot is being focused on autoimmune disorders, because it does seem like the majority of individuals with schizophrenia have some type of autoimmune issue. And there's like a lot of experimental treatments towards that too, like treating autoimmune, or basically treating for autoimmune disorders, even if they aren't identified to have that, because it can be really hard to capture if there's, especially like a autoimmune encephalitis brain, that have some promising outcomes. But you know, it's a disease that seems a bit different than like depression or anxiety, even though, I mean, it's definitely like on the extreme end of anxiety, like it's kind of similar.
Yeah.
It would be great if we had more biological treatments that had fewer risks or negative impacts on people. And with regard to treatment, I mean, things are moving way more towards not like challenging your thinking necessarily, but let's literally get you into the community. I'm going to take you out into the community. We're going to talk about social skills. You're going to order your coffee, and we're going to praise you for what you did. And we're really focusing on goals and focusing on your strengths. I think
Person-centered kind of
yes,
approaches. Yeah.
I think that's really where things should go. And there was something else I was going to say about that. Oh, I mean, I've wanted to do this forever, and who knows what will happen with all of the crazy stuff that's going on right now that I won't mention. But there are communities for, like in Scandinavia, for example, like dementia communities, communities with people with schizophrenia that are like self-sustaining communities where everybody has a job there, right? And they're integrated in the community also. But they have all the treatment that they need there, pleasurable activities. They're really wonderful, and they seem to work really well.
But where they're still integrated into the general community that they live in, but where it's embedded support, essentially. Yeah.
That would be absolutely ideal. Because people also need to meet other people that have schizophrenia.
Yeah.
Right?
Well, and I think so, and it's interesting, and obviously for anybody watching, maybe this is interesting, maybe it isn't. It is to me. Thinking about even the approach of, so in Western New York, we have a lot of districts who have what we have, which is a family support center, kind of a hub embedded within the school district, but that kind of serves as an intermediary between, you know, community services, school district supports, et cetera. And, you know, making sure that whether it's community mental health organizations, whether it's places like us, whatever you want to call it, a family support center, a family resource center within a school district, that these services Although certainly respecting privacy and respecting confidentiality are not hidden within a community. And I think the model that you're discussing in the various Scandinavian countries and probably some places elsewhere as well are models that are utilizing an openness to these certainly to these treatments, but making sure that they're integrated into the community and that they're not these hidden places that you only go when something's wrong.
Yeah.
And that no one needs to know that you're going there. And
Mhm.
again, there is a place for confidentiality, certainly, and there is a place for privacy, certainly. But it's hard to feel dignified when everything that is required for you to feel better is kind of hidden.
Yeah.
And I think that there's a long way to go in terms of how school districts operate and in terms of how even communities operate with regard to, how we approach mental health. And I think so, and even other aspects of physical health too. But I think the more that we can start integrating, like you said, these services, instead of doing it within a clinical setting,
Yeah.
but doing it within a community setting, I think it creates a lot more dignified approach to that treatment, but B, it allows for a normalization of these things, that these are your neighbors. These are not some people that are tucked away in a hospital somewhere on the corner of your county. These are your neighbors, these are your classmates, these are your colleagues. And that allows then for kind of coming for a full circle back to kind of tie it up to, I think, what was the main theme of your presentation in terms of how do we treat people with either serious or even less serious mental illness. It comes down to empathy, and it comes down to relationships. And it's really, really hard to do both of those things in isolation and outside of a community. So again, I want to thank you for, certainly for reconnecting. It was really nice to do that, but for being able to provide our community and our school a little bit of insight into, some of the more serious mental illness that they might encounter and how to best treat it and how to best support people that might be experiencing it. So, Aaliyah, thank you again. And I hope we can reconnect and do something good for the community again.
That's awesome.
All right.
Thanks.